Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today, as always, by my fantastic co-host. I was going to say Sparky because, well, 4th of July.
Yes.
Sparky co-host, Dr.
I'm a sparkler of a surgeon.
He is a sparkler of a surgeon. Dr. Jason Martin. He's a board-certified plastic and reconstructive sparkly surgeon.
Yes.
Dr. Martin, how you doing?
I'm feeling sparkly.
Yeah, I love 4th of July. I think we've well established how much I love the national anthem.
Yeah, I love it. We're very patriotic. We love fireworks.
Yeah.
We love summer.
Yeah.
In Colorado, to make it very clear.
Yeah, it's a short season, but we do love summer, and I love the national anthem, and just so thankful and grateful for everyone who serves. So if you are part of our armed forces or in any way support the country,
come to Beauty and the Surgeon.
We're huge fans.
We know that you listen to us all the time, all you soldiers
People
out there.
People get surgery of all kinds. Yeah. We have soldiers.
We support you. Maybe we'll do a soldier episode or something.
Yeah.
Okay.
So if you are listening to this podcast and you'd like to watch us, there is a video that goes along with it. You can find that on YouTube at Jason Martin MD. You can also find all of our social media handles here. We're at Jason Martin MD and at Beauty and Surgeon Podcast, everywhere you find podcast info and social media and all those fun things. You can also leave me a voicemail or send me a text at 303-630-9038. We have many episodes where we answer questions and listen to your fabulous voicemails. Bash in the Boob is still my favorite one, maybe of all time. Or the patient who we talked to the other day, and I'm like, oh my gosh, I know her. She left a message. So
my favorite was the recent one was the lady who called you Miss Amy. I still want to do that.
Love her.
Very
yes. She actually sent me a follow-up text after, which was really awesome. She ended up doing the surgery. It was very cool. So
very good.
Yeah. So we love your comments. So please do leave us a comment. So as you can see in the title, this is everything you need to know about rhinoplasty or nose jobs part 2. There is a part 1.
Part 1 was awesome.
In part 1, we talk about the tragic tale of celebrity plastic surgery, aka the story of Jennifer Grey, and also the statistics and who's a candidate and what to do when you're looking for a surgeon. So in this episode, we're going to talk...
And what to expect at the consult, too.
Yep. This episode, we're getting into it. We're going to talk about the anatomy of the nose. We're going to talk about how the surgery is actually performed. We're going to do a deep dive on recovery and also help you understand what to expect prior to surgery so that you can be well prepared for recovery.
Perfect.
All right. So let's jump into the anatomy of the nose.
Which is hard to even understand when you're a surgeon, but... So the best way to do this, and I think in one of the previous episodes we did this, is where I divide the nose in thirds, the upper third, middle third, and lower third. The upper third is bone. That's what you feel. If you feel, Nils, get your microphone. Yes. Touch your bone. It's very uneven because you've been hit like 100 times.
Mine's a little chipped up.
Yeah. So you got the upper third, which is bone.
Yep.
The middle third, squeeze that. That kind of obstructs your airway. Yeah, that's the septum. And the upper lateral cartilages, and the lower is the tip, which we know that. You also have the ala, which is your nasal airways. And then associated underneath, you have different sets of cartilage, a septal backbone, and nasal bones. And that's what really makes your nose. You also have a skin envelope on top. Amy's used the analogy before of a tent, and that truly is the old school A-frame tents, not the newer ones, where you have a pole in the middle and the kind of like the tent goes on the outside.
Yeah, or like sails.
Yeah. And that's basically what a nose is. So you can have over-projected lower lateral cartilages. You can have prominent upper lateral or septal cartilages, which makes it, your profile look weird. You can have asymmetry on your nasal bone. So there's so many different presentations on the nasal anatomy. What else can you add to this, Amy?
As far as the anatomy goes, I think, understanding that a lot of the nose is very flexible, I think, as we all kind of know, because you can manipulate it with your fingers. You can push it around where you can't push around your forearm bones. Those are bones. So when you address these things, that's why we talk about rhinoplasty. We talk a lot about this in our first episode. You only get one go at your first one, because if something goes kind of awry or some of these softer, more malleable parts of the nose are changed, it can be hard to go back to where you started from.
Right.
Yeah.
A good example is columella, right? In between your nasal airways. This is the kind of skin and soft tissue that when you kind of grab up towards your nose that you can feel. That actually has cartilage in there and soft tissue. You can violate that. That can be distorted looking in the end. It can hang lower. It can be retracted up. I mean, that's just one little area, and that's the entire nose. There's also these attachments, these little ligaments on the inside. If you disrupt those, your nose can change in its shape completely. So
yeah,
there's so many different things.
It's a lot going on. I mean, this is kind of like when we do the deep dive on the otoplasty, like the parts of the ear. I mean, these are fascinating structures because they are a mix of bone and cartilage and so many little tiny things, and a lot goes on inside the nose. I mean, it's where we have a lot of our basal level immune defense because of all the little hairs inside the nose.
Yeah, we're not even talking about the airway. We're just talking about the cosmetic stuff. But it's simplified. Bone on the upper third, cartilage in the middle, which is that septum or that tent pole, which tends to affect the profile. And then the nasal tip below is also cartilage and some septum too.
Soft tissue. Yeah. So it's complicated structure.
That's all you need to know.
And you'll find way more complicated pictures than this online. Like this is the most simple picture of the nose I could find. And it still looks like there's still a lot. So yeah. Okay. So you have gone through all of our first episode on rhinoplasty. You have picked your surgeon. You are at your pre-op appointment. The things that are going to happen at pre-op, they're going to take pictures.
What if I don't want pictures, Amy?
They're going to take them anyway. You need a lot of pictures taken. And these are for your medical record. So anytime you're having anything changed on your body, you should have a record of how it looks before and after.
It's for you. It's not for us.
Yeah, these are not self-promotional pictures. You're going to review your health history. Again, you went over all that at your pre-op or your initial consultation, or you over it again at your pre-op appointment. Send you in for pre-op labs and testing. You might need an EKG if you are over 50. You might need other...
What if I don't want an EKG?
Are we playing some kind of game that I don't know the rules to? Like, what is happening here?
These are the questions I've had in the past 3 weeks.
That's just it. The answer to that is that you will have the tests that are recommended by your doctor, or you will not have surgery with that doctor.
Exactly.
There we go. The answer to all of those things you're going to ask me is this will happen and or you will not have surgery with us.
Right. I feel like I'm speaking to one of my children when you hear that.
Discuss your pre-op labs and EKG. Like I said, we'll sign consents. So we'll sign the consents for the hospital. We'll also have you sign the consents from the American Board of Plastic Surgery. Collect your final payment, give you your prescriptions, review the date and time of your surgery, answer any questions that you may have. So those are kind of like the big overview. But there are some really specific questions that go along with this surgery that I think you absolutely should ask at your pre-op appointment, aside from where will the surgery be and where will I be taken after surgery, which are kind of basic ones. Starting here, Dr. Bryan, I think this is the number one question I get at rhinoplasty.
Yeah. Will I have a splint? Will I have something packing inside my nose? Will I have dressing? So usually the packing inside the nose or splints inside the nose, the nasal airway, or when the septum is violated, either for cartilage or septoplasty for airway purposes. So if they don't need to take septal cartilage or address your septum, which again is the temple in between, from inside the nose, then you probably won't have splints. You will most likely have something on the outside.
Yeah, like a little soft cast.
I mean, it's either tape or something a little harder, especially you have the nasal bones are infractured, which we'll go through.
Packing is pretty rare anymore. I feel like it used to kind of just be the thing. They would just pack everybody's nose, but
I feel like we totally did that.
Yeah, and like I can't think of a time recently that we've packed anybody's
never.
nose.
It was funny because I did a surgery today with my chairman visited, the guy who trained me a long time ago, and I kept thinking about all the stuff he did, which was extra, and I didn't do any of it. And I almost started doing it just because he was there. It's just like, what am I doing? I'm not going to pack the nose.
No.
What am I doing? Out of respect, kind of. Yeah.
Yeah.
Glasses, probably not right away. Contact lenses,
they
Amy.
Sit on the bridge.
Yeah. What about contact lenses?
Contact lenses for most patients, you can put those in, a day after surgery, especially if we're telling you can't wear your glasses. In a lot of cases, when you have that like hard splint on your nose, you can put your glasses kind of resting on it. But it's not going to be, we don't want you having pressure there, especially with swelling. I actually had a patient come in who was about a month out from surgery and noticed she called and told the front desk she had a bump. I'm like, well, I got to see this bump. She came in the next day. I'm like, this is where your glasses sit. Like you need to start getting switch out to different types of glasses while you're in recovery because they're continuing to put pressure on the same spot. And it's just a little indent in the inflammation. That's all it was. So she started wearing glasses that had a different type of little nose piece and it went away like magic. So usually you can wear contacts within, I would say 48 hours of surgery, but definitely that's something you should ask your doctor because they might have a different recommendation. And if you can't wear your glasses and you can't wear your contacts, your world might be real small for a few days. Mine would be. It would be about as far away as this computer. That would mean no driving, no grocery shopping because, oh my gosh, I feel like I'm...
So crazy how bad your vision is.
Being in the grocery store is real scary without... Because it's like you can't see till you get right up... I mean, right up next to
So your
something.
face is right in the melons?
I mean, it's like...
You're motorboating the melons?
Like, which yogurt do I want? I'm like right up on it, yeah. Like, she really likes melons.
She really likes melons, man.
Yeah, it'd be more
Maybe
like
that's why you're not getting as many dates.
Right?
You got to wear your glasses to the store.
Clutching the melon and just like watching
Smelling it,
yeah. When can I shower? This is a big one. The really big question I get asked, when can I blow my nose? Because you feel like you want to because it feels congested. So that is definitely something you need to ask your surgeon. When can I drive? Again, if you can't wear your glasses or contacts, you definitely need to wait till at least that time. And when can I return to normal activities and exercise? If you play sports where you might get hit in the face, This is especially going out to college students who might be like lacrosse players and or something.
A lot of those.
Yep, or volleyball.
Volleyball for women.
Tennis.
For sure. Tons. Tennis. Yes.
That recommendation may be different. Your doctor might not want you doing those high impact sports for maybe even 6 months.
Maybe 6 months. If you have to fracture the nasal bones, with most of the time these kind of kids you do, even if it's an anatomic sparing rhinoplasty, which we're not going to get into the weeds on all these techniques, but I mean, the reality of it is you may have 4 or 6 months before you can get back to anything that has potential for injury.
Yeah, for being hit in the face specifically.
Unless you're a hockey player, then you just wear a different face mask and you come back out like a week later.
Yeah.
Well, all they did was set your nose. They didn't give you a rhinoplasty, they just reset it, send you on your way. All right. Let's talk about the risks before we start talking about the surgery itself. Let's talk about some of the risks, because no surgery is without risks. I would say this is a pretty low risk surgery, especially from the kind of typical ones of like bleeding, very low risk.
If you go to someone who's competent, it's a pretty low risk surgery, honestly. And that includes the outcome itself. But like the actual risk to occur with the surgery are pretty small if you go to someone who's competent.
Yeah, and they're your basic risks. I mean, obviously you're having anesthesia, so the risks of surgery in general are going to apply just like they would to any surgery. Bleeding risks, infection, need for additional surgery, swelling and bruising are expected, but yes, changes in sensation or numbness. You'll have numbness. And we talk about that a lot in our episode from a month or so ago or 6 weeks ago about numbness after surgery. Even just changes in sensation, like touching it can feel weird, some difficulty breathing that is temporary. There is the risk of having a permanent change in the way you breathe, especially if you did not have any addressing of your breathing issue prior to surgery. It might be worse after.
Yeah.
Can
I say something to that?
Yeah.
So when you narrow the nose, there's something called an internal angle on the inside. You can look that up, internal angle. And you can make that angle more acute, which can then actually decrease your ability to breathe correctly through your nose. Mm-hmm. So I'll do exam, even if I'm not going to address the airway, I'll do a caudal exam, a caudal sign, where just like a breathe right strip where you pull the cheeks out. If there's a huge improvement in people's breathing, everyone has an improvement. I was
say that feels good.
But like a huge one, like, wow, that's totally different. Then you may be at risk for narrowing that internal angle. And the answer to that is something called spreader grafts. So nasal septal perforation, that's a real risk. If you're addressing the septum, it can be a real problem. Those are real hard to fix, actually.
Yeah, it's a
perforation.
Hole. Yeah, essentially.
Skin discoloration, that's guaranteed. If you have bruising, you get hemosiderin staining, so that kind of huey, how would you describe that? How that
just looks? Like a bruise that kind of lingers.
Yeah.
Yeah, like a faded bruise that like lingers.
Pain, definitely it's painful after the surgery. Definitely if you have fracturing of the nasal bones, less so if you don't. But it's very tolerable. Mm-hmm. We've had a few patients have prolonged pain, but that's very, very unusual.
And it's not even real. It's rare to have pain. I mean, I've broken my nose, as has Nils, a number of times. And yes, it is very painful. And things like letting water touch it in the shower, or even like, well, that's the worst because you think it's better and then you hit it with the water. Oh, yeah. That's what gets you. So things like that, like, yeah, it hurts them, but does it hurt the rest of the time? No, which is why you forgot and put your head in the shower. So it's rare that you have like pain. It's more just annoying and discomforting.
Yeah. Revision surgery is not uncommon after rhinoplasty. It's one of the issues with this because rhinoplasties are hard to make perfect. So at least in our hands, it doesn't seem to be very high at all. Maybe the revision might be something in the office, something little, but that's something that you have to know is a risk. And persistent asymmetry or asymmetry you didn't have beforehand. Mm-hmm. So these are all real risks. It's a very good list, comprehensive.
Yeah. So you should, if one of these like really jumps out at you as a concern, talk to your surgeon about this. If they can't explain why this is a risk to you and why, you should not be concerned or why you should be concerned based on your presentation, maybe go for somebody else who you also feel comfortable with. See episode 1. All right, let's take a quick break. And when we come back, we're going to get into what everybody is really here for. They want to hear about the surgery. People love hearing about surgery.
I can't wait.
And we're back. And now we're going to enter the podcast OR and talk about surgery.
Yes, we're bringing you in with us.
All right. So we're going to go through step by step. First step, anesthesia. These are going to include choices of intravenous sedation. There's very rare cases where maybe it's a really minor thing and you get some just local anesthesia in your doctor's office.
Which you can do. You can do some of these in the office, like tip plasties you can do in the office.
Or weir excision. Yeah. But we're for the sake of this, we're talking about OR surgery. Your surgeon is going to recommend the best choice for you. Now, there are, of course, breathing issues to consider when you have anesthesia. So they're going to make the decision that is best for you to keep your breathing during surgery.
Like sedation is definitely doable for most rhinoplasties. The problem is when you do, especially infracturing or more invasive rhinoplasties, that you can have bleeding behind your throat. And if you don't have a tube in, which helps protect your airway, then that blood can get back into your breathing tube, basically through your vocal cords down into your lungs and cause coughing. Then you can aspirate that. You can have pneumonias and stuff like that. So a lot of times people will just put a tube in just for airway security. But I was trained with sedation alone for most rhinoplasties. So it just depends on what the surgeon's preference is.
Yeah. All right. So the incision.
So if it's open, the incision would be at the base of the nose through the columella, a transcolumellar incision that goes up on the sides of the columella and into underneath your wings of your nose, the nasal airway. Amy, how would you describe the columella?
It's the part in the middle. We talked about that on our anatomy slide.
Nice. Mm-hmm. Okay. I totally remembered that.
You described it perfectly.
Yeah. If it's closed, you still do have incisions with closed, okay? But they're inside the nose, basically where you stick your finger in, you kind of feel this lead. So that's where you do those incisions. So those are substantial and probably just as long as an open incision. They're just inside the nose. You can have poke incisions also near the nasal bridge, usually with infracturing or other small things. And then the weir excisions or the wings of the nose, when you want to make those more narrow, those are at the edge of your ala, where the crease of the wing of the nose meets your cheek. So that where that crease is. So those are usually the 4 types of incisions that you would see.
Yeah, and they're all really well hidden. They heal extremely well. We've never had to do a scar revision on a rhinoplasty. They're really well hidden. Even when they come up around the edge of that ala, they're extremely well hidden.
Yeah, I think the whole discourse between open and closed is overblown.
Yeah,
I think it's just marketing tools, like people that do closed, like you should never do it open. It's the worst thing ever. No one's ever seen that open scar, ever.
No.
But I do like closed too. I think it's a cool way to do it. I think closed is better for the upper 2/3 of the nose, and an open is better when you have to do the tip. That's the truth. It doesn't mean you have to do it that way. It just exposes everything better.
Yeah. And there are a lot of times people ask me, they're like, I have a stitch near my eye. And that's from that, where we might need to go in and put a little tool in at the top. So don't be surprised if you come out and you have a little suture like toward your eye that seems like it's just random. It's not. That was used. So then this is everything's open to the point that we need it to be, whether it's an open or closed. We've made all the incisions that are going to be made. Now the work happens. This is when the reshaping. So explain the reshaping parts.
All right. So we go through the rhinoplasty, and I'll just do it the way I do it, but that's just pretty standard. You open everything up. You expose it through an open or closed approach, right? You expose the tip of the nose if you need to, if you're going to do something with the tip. You expose the bridge of the nose going all the way up to where the bone is. So the upper third of the nose too. But that's only in the midline over the bridge. It's not on the sides. And then the first thing you do is you improve the profile. Okay. And Amy, how do we improve the profile of the nose?
Typically it means kind of shaving down a bump or adjusting the slope of the nose.
Right. So a normal profile kind of goes with the nasion, right? Where your nose meets your forehead. There's a little bit of a dip there, and then the profile usually at least goes pretty straight down to the tip of your nose, and then you have something called a super tip break where the tip then elevates up and over and down. So for taking down the profile really comprises the upper third and middle third of the nose. So what is the upper third of the nose, Amy?
Bone.
And what is the middle third of the nose?
Cartilage.
Right. So you take down the cartilage in what we call component fashion, which is septum and upper lateral cartilages. You can go back to our anatomy slide. Actually, Nils can show it right here. Thank you. And then you take down the bone with rasping. I remember the last time I tried to describe rasping, and I felt very terrible about it.
It's like a cheese grater.
Yeah.
Oh, or what you used to
sand
shave.
It down.
It's like nutmeg, like what you used to shave nutmeg.
I don't know any good way to say what we do, but we do something.
Rasp it.
Magically remove bone. So, and that's where you're always looking from the side. You're having the staff look, your assistant, you're looking and saying, oh yeah, I like the way that profile looks. That's the first part. The second part, Amy, is that you may need to infracture the bones. And you do that when you have to take down the nasal bones and create something called an open roof deformity. Infracturing of the bones really brings the nasal bones together But more importantly, why it's important to you is it also narrows the nose. If your bridge of your nose, specifically the upper third, but even going into the middle third, is too wide, then doing the fracturing of the nose can narrow that nose and make a big, big difference. And, it's so funny. We do so many of these. The remarkable changes are usually in the narrowing of the nose, which is something like afterthought. Do you know what I'm saying? We just had someone like that recently.
Yes.
Where you were saying, man, the narrowing of her nose made the biggest difference.
The biggest difference.
Yeah.
Yep. And that's in that facial harmony. That's what made the difference, even though the tip was what bothered her. We had originally planned for a tip-only rhinoplasty on this patient.
And of course, I modified.
Yep. Ended up, when we saw her for pre-op, no, we changed the plan. We're going to do
everything. Yep. And then you finalize, you do the tip, and the tip is narrowing of the tip. If you have a bifid tip, or as we called a patient said recently, a butt tip, you have two butt cheeks, one on one side, one on the other. You can make that less too butt cheek looking and more like a homogeneous single tip.
Decrease the nasal gluteal fold.
You can make the tip more pronounced or protruding, less protruding. You could make it more subtle. You can narrow it. There's so many different things you can do. Along with that, you can add grafts to support the tip, an onlay graft, shield graft. You can have grafts over the ala. There's all these different procedures at this point in the procedure, or there's all these different techniques at this point in the procedure that you can do. And then after you're done, you irrigate things out and you close it up. A standard rhinoplasty for me would take about an hour and a half, but we have some of the fellows who rotate with some people, and they take 4.5 hours for rhinoplasty.
Which is crazy. The longest I've ever scheduled, just you, not a combo case, because we've had some complicated combo cases with ENT where they've needed a lot of internal work on their nose from an airway specialist. 2.5 hours.
Yeah.
And that was a complicated revision rhinoplasty. There was a lot going on. So that does seem long, but it takes the time it takes, and you've chosen the surgeon you like. Go with it. The difference between being under anesthesia for 2 or 4 hours is not drastic.
There's no difference. Yeah.
Get the rhinoplasty you need. And so the closure, they're simple, which means little simple sutures. I've seen some doctors run that incision. I don't like that as much. I think that should be simples just because it is so tiny and they're so delicate. And
I'm sorry, in the airway though, inside the nose, especially with closed, sometimes we'll use absorbable sutures that don't need to be removed.
Yeah,
it doesn't make it better because sometimes you put your finger in, it feels hard and not right. So
yeah, well, and we tell people because the sutures that are rapid dissolve, they're a kind of blondish color, so you can usually see them, and then they will fall out on their own. Yeah. So they don't usually bother people. If they are, I'll cut them out too, as long as they don't mind me reaching up in there.
If you have splints in or any kind of packing, and again, that's not common for us. Those will come out about 5 to 7 days in most cases.
Yeah, and they'll be put in place while you're still asleep. So you'll wake up with whatever you've got going on will be there when you wake up. So that's it. And we made it sound pretty simple for a very complicated surgery.
Such a simple surgery.
Yeah.
It's literally the hardest surgery we do, pretty
seriously,
much.
Go back and listen to that again. Because there's a lot. You covered that extremely well, but it is the nose is complex. It really is.
It's three-dimensional through small incisions. You can barely see the aspects of what you're doing. So it's very technically hard, which is why most people don't do rhinoplasties because it's a technically hard surgery. You have to either have special training or an interest.
And special patience.
And it's like a one shot, right?
Your first time.
First time. Yeah, you can do multiple ones, but it's really important to get it done at first, like a facelift the same way. Okay.
All right. So let's talk about how you can prepare for recovery. And I call it preparing for recovery because it's good to think about this before you are actually recovering. These things will help you a lot.
Crazy thought.
So make sure you read your pre and post-op instructions and review those with your primary post-op caretaker. This is probably where I get the most, and rightfully so, panicked messages from the caretaker, oh my gosh, X is happening. I'm yep, that's totally normal. And I hear the person in the background going, it's fine. Because they knew, but they didn't bother to tell their caretaker. And at the time, the caretaker's you are on a lot of drugs. I'm not going to listen to you, crazy person. Yeah. This seems scary. I'm going to call. So, go over those things with your primary caretaker so that they don't have to be worried about you unnecessarily. Know when and where your first post-op appointment will be. We tell this story every time. We had a patient whose husband took her back to the hospital. He'd never been to our office. That's what he thought. This is where the doctor is. Hospital.
Surprise.
Yes. It was not. So, and the hospital is about a 30-minute drive from our office. Make sure you get prescriptions filled. Please listen to that again. Put it on repeat. Make sure you get your prescriptions filled prior to surgery, please. Purchase any recommended post-op products. In this case, it's probably going to be some wedge pillows to facilitate better sleep and ice packs. It's pretty simple. They're not a lot to buy. Everything else you just have to have on you, which is your nose, and you've got that. Think about what you use on a daily basis and move these items as close to counter height as possible because you do not want to be bending down or looking up. I think that's what surprises people. They think about bending over, not feeling good because like head rush, but they don't think about how uncomfortable it might be to look up. Some of that's because you're swollen, right? So you look up and you just have like weirdness. And then just the pressure when you look up is going to be as intense as it is when you bend down.
Right.
So waist level is your friend. What do you always tell people? Make a recovery statement.
Yeah, recovery statements. That's my big additive to the recovery recommendations that Amy pretty much covers everything.
Yep.
But I love recovery stations. I like that thought.
Yes.
It's like end of the world prepreration.
But it makes
sense. You know
sense.
what I'm saying, Nels?
Yes.
Yeah.
You know where your medications are.
You have like a Swiss Army knife there. You have some
Maybe
popcorn.
Don't use a knife.
I'm joking. I mean,
stations, even when I'm not recovering.
Exactly.
It's like having everything laid out for a movie. I got my snacks.
Right.
Got the remotes.
Got the remotes.
Phone charger.
You're feeling it. You're feeling it. Yeah, so the recovery station is super important, especially if you live by yourself or maybe your caretaker has to go to work or whatever. So head needs to be elevated, ice on the eyes for sure. Recovery station should have your pain medication, any remote controls that you need, fluids, maybe some snacks or foods that are palatable, that kind of stuff. And then other stuff that you might want, lip balm, things that are important to you.
Yeah, you will be dry. Plan on a few days of easy to put on clothes and slip on shoes because again, bending over, slip on shoes, slip on shirts, nothing that needs to go over your head because the last thing you want is to accidentally snag your nose that you cannot feel because it's
Which
numb.
you probably do all the time, but after rhinoplasty is the worst pain you've ever
or even
had.
pulling a shirt over like, well, that was a mistake. And then you have to get it off again. Like, oh gosh, like you just sleep in that shirt for 4 days. So like, you're like, no, I don't need to take this shirt off or shower. I'll shower with it on. So definitely think about your clothing choices pre and post op. The lip balm comment was actually a fantastic one,
That's
Dr.
what
Martin.
I do. That's what I do, Amy.
Yep, because you will be breathing through your mouth primarily, and that will dry out your mouth so much. And also your nose will be kind of runny, drippy because you can't really sniff well because it's, numb and swollen. So you'll be having this like front nasal drip, not post nasal. It's coming out the front and you're breathing through your mouth all night long. So your mouth is dry, your lips are dry. So lip balm is so key. I can't believe I didn't put that on the slide.
Yep.
Look at that. It's Beauty and the Genius today. Yes. And it's normal.
I don't need no Amy.
Right? It's normal to be nervous.
Actually, I really 100% need Amy. Like every single day. So
I'm like a security blanket.
You are. You're my support animal.
Yes. And it's it's normal to be nervous and excited. These are normal things. This is just surgery. Even though it's elective, you still can be nervous even though you're excited. So that's totally fine. All right. So what should you expect during recovery? So you're prepared. You've got all your stuff.
So let's just talk about right away.
Yeah.
You're going to be swollen. Eyes will probably be bruised if you had the bone work done. It'll be discomforting. It'll feel
pressure.
It'll feel like a gnawing discomfort, not like usually a sharp pain, but you can have sharp pain. Definitely have bruising. You're going to breathe primarily through your mouth, which is super annoying.
Yep. Like a sick baby. Yeah. Oh, the first time your baby gets sick and they can't breathe through their nose, they're just like screaming about it.
It's not physiologically good for you to only breathe through your nose or through your mouth, So, which is why people have trouble sleeping sometimes when they only breathe through their mouth.
Oh, do we have enough to link the episode stuff we're into where I talk about mouth tape? There you go. Learn the benefits of mouth tape and why you should not breathe through your mouth.
Yeah. So there's nothing to judge at first. When you watch the reality shows, The Swan and stuff, they say it's just a week afterwards and they're perfect. It doesn't work that way. They save the splint and just take it off, more weeks after that. So they look really good.
Yeah, so you'll be bruised.
Sorry to burst the bubble there.
You'll have swelling. You'll have black eyes, most likely. You're the tip of your nose, especially for people who wanted it smaller, it'll be even bigger because it's swollen. Don't let any of that freak you out. The splint also is going to force inflammation down into the tip again, which you wanted to be smaller, which now looks bigger. Totally normal. Just give it some time. But for that first week, limited activity, meaning you can walk, but you don't want to do anything to get your heart rate up. Again, because you're breathing through your mouth. You can't breathe that well. You don't want to be breathing heavy. Sleeping on your back at an incline. Pain medication and muscle relaxants. Most of our patients maybe take the pain meds the first day and the very next day have switched to Tylenol because it's not like it's that much pain as long as you're not touching it. It's just sore and congested feeling. Now, if you bump it, it's going to hurt, but don't do that and it won't hurt as much.
Sometimes it's hard with sleeping, but
That's where the muscle relaxants come in nice too. We give you it just helps you relax, And if sleeping can be an issue just because you are at an incline on your back, breathing through your mouth, you're drooling all over yourself. It's just not fun. I'm making this sound great. You've got the splint in place, unlimited easy walking. And you might be able to return to work if you work from home.
If you're off pain medications, you could probably return to work if you work from home.
Yeah, absolutely. Or if you don't mind.
The Zoom calls might be a little bit funny, but.
Yeah, but you could be working, as long as you're off pain meds within a few days for sure. Weeks 2 to 3, you'll definitely be able to return to work and driving. You'll be feeling much better. That feeling of just kind of constant congestion will be improving. You can wear your glasses again. switch up the pads so you're not wearing the same pair of glasses all the time if you can, and returning to some exercise and more activity. Weeks 4 to 6 is where most people are like breathing through their nose again, like consistently, like really breathing. You know, like right away you breathe a little.
Yeah. And that's right around the time you're like going back to your normal activities, right? So like more exercise, you're feeling pretty good.
Yeah. You're back to most pre-op activities. You might start using a little bit of topical scar ointment. You'll definitely be using sunscreen on your whole face and still keeping that scar protected from the sun.
Amy, when do we start swimming?
That's on my week 7 and beyond. Swimming, it's just regular swimming, like having your head in kind of swimming. Around 7 weeks is probably fine. If you are a scuba diver, might be a little longer. That, again, that pressure on your nose and the internal pressure you need to produce to equalize, we don't want you causing that for some time. So I would say if you're a scuba diver, I would plan 12 weeks before scuba diving. What would you say to that? Yeah. For that same reason, we love...
That's true for any... Sorry to interrupt, but that's true for any activity that has potential for damage or traumatic injury.
Well, and even longer with like sports.
So lacrosse, sports.
That's like months.
Yeah.
But we love hyperbaric oxygen therapy after surgery, but this is one surgery where I can't recommend it because you can't be doing those maneuvers to equalize the pressure in your ears. And it's extremely dangerous to not equalize your ear pressure when you're in a hyperbaric chamber. So if you have a rhinoplasty, you probably have to wait at least 4 to 6 weeks before you can start doing something like hyperbaric. But the good news is there's lots of other things you can do, like cryotherapy and acupuncture right away that'll help you with bruising and swelling. Hyperbaric in this case is just not one of them for the same reason you can't scuba dive right away. Pressure. Okay. Pressure is key. You can side sleep again. You can sleep flat and you can love your results. This is one of those surgeries that once the swelling's gone,
it's awesome.
Yeah. Like it's right away. This is one of it's not quite the instant gratification of like a direct excision neck lift or a breast augmentation, but it's pretty close. It's the next best thing.
Yeah. Especially if it your profile has a big bump on it.
Mm-hmm. Or you had a really hooked tip.
Yeah. You can see it right away in that sense.
Or if it really deviates. Yeah. Yeah. It is fun because you take that splint off, you're like, oh my gosh.
Yeah. It's like the grand reveal.
Yeah. It's pretty cool. Well, that's it, Dr. Rowe. We have now covered everything you need to know about rhinoplasty.
Yeah, I feel like the listeners can now do rhinoplasties. Mm-hmm. Should have rhinoplasty parties where you guys do it on each other. Just forewarning, it's one of the hardest surgeries we do. The fellows have no idea what's going on, even though they've studied it.
But that's because you can't really see it.
Right, you can't see it. The anatomy is difficult to fully comprehend. But I think once you do it, it kind of really starts to reveal itself.
Yeah. So
rhinoplasties can be very, very complex and involve lots of grafts and lots of special stuff. And I think that's important. But I do feel my philosophy is to try to find the simplest path forward to make sure people have that nice middle ground result. It doesn't mean it's not super transformative, an amazing change, but it's really important that you don't, from my opinion, want to overchange the nose either. I think that's really, really important. And that's why...
See Jennifer Grey.
Yeah. And that's why I think there's so much consternation about this surgery. It's one of the more polarizing surgeries there are, because people think about these bad results and you never want to be that person either. So just be empowered. Hey, whatever results you want, just go to someone that'll give those to you. Even if that's a big change, that's totally fine.
Yeah. And some people do need a big change or want a big change for whatever reason. All right. So thank you everyone so much for listening to this episode. I am going to give myself lots of props because I did not make any tip jokes.
That's true.
Single one. Yeah. I pat myself on the adult back.
I know. I thought them.
I thought them. Yep. But they did not come out.
Yeah,
so
that's good.
If you made it this far in the podcast, we really appreciate you listening. We hope that you will listen in again, even if it's on a topic that you might not find super interesting. Go back and listen to our Stuff We're Into episode. It was really fun. Find out the stuff we're into. It's a great episode. Or listen to the questions from viewers because they are always amazing.
Those are my favorites.
Oh, they're my favorite. You can find all of our social media links again right here. And again, my phone number, if you want to call me or leave me a voicemail, send me a text, is 303-630-9038. And we really appreciate everyone for listening.
That's all I got. My favorite surgery. Please call us up. I'll do this every day all the time. I'd like to do rhinoplasties all the time. I don't think that's going to be the case, but...
Maybe.
We'll see. I'll be the rhinoplasty king of Colorado.
Colorado.
Alrighty.
Bye.
Bye.